So the next presentation comes from Germany. Stefanie Schmickler is going to share her case of cataract surgery after previous radial keratotomy with its power calculation task, which was very difficult here. So Stefanie, please go ahead.
Hello, I'm Stefanie Schmickler and I have a case report on a patient for cataract surgery after RK in the past. It is a 60-year-old lady coming in having RK in 1992. At that time she had minus 6.25 diopters in her right eye and in her left eye minus 6.75 with minus 0.5 cylinder, axis 170. Both eyes she had 20/20 visual acuity, and now before cataract extraction she suffered again from moderate myopia, and she had a myopic nuclear cataract in both eyes. Visual acuity in right eye was 20/50 and in left eye was 20/30. We did biometry with a holiday formula, knowing that it is not the right formula for a patient having had refractive surgery. But nevertheless, you have a guidance where you should reach around. For right eye, we had a 19.5 diopter Hoya lens, and for left eye, a 25 point diopter lens. This is the IOL master. You see it was a good measurement, and here you see the pentacam, and you can see in right eye and as well in left eye the very high order aberrations, more than 1.0 micrometers. Then I did the Oculix measurement or Oculix biometry, which is based on ray tracing in combination this time with the pentacam, and I got for the right eye Hoya Vivinex and plus 26.5 diopter, and in left eye 27.0 diopter. This meant there is a difference in the right eye between the IOL master and pentacam of 7 diopters, and I asked myself, this cannot be true. And therefore I contacted Professor Preussner, who invented the Oculix ray tracing software. And he wrote me that the eye has an extremely oblate spherical cornea. You saw it in the pentacam. The IOL master keratometry underestimate the normal cornea radii, which means that the corneal power is overestimated, and the refractive results are dependent on the pupil width. And he recommended me to correct the spherical aberrations with a Technis PCB lens. Therefore, I ordered a Technis lens in 26.5 diopters. On the day of surgery, I had the idea to do a new measurement with the CIMA Galilei and the Oculix ray tracing software. And here you see the results for right eye and for left eye. And you can easily see in the Oculix software that there is a 20.0 diopter lens now for the right eye. This means there is a 6 diopter difference between pentacam Oculix and CIMA Oculix software. Now, what to do? The patient was already waiting in the waiting room. The patient's pupil had already been dilated. I told the patient the truth, that I have now 2 different measurements. I contacted Professor Preussner, and he could only rely on the pentacam measurement. And therefore I contacted Professor Langenbucher from University of Hamburg-Saar. Professor Langenbucher is the founder of IOLcon.org. He asked me, the measurement of the corneal radius is so different between the pentacam and the CIMA. In the Oculix software, 9.5 mm pentacam versus 8.7 mm in the CIMA. The pentacam interprets the actual central radius and CIMA a little bit more in the periphery. But if I assume that the cornea before the RK was rather normal, also fits to the eye length of 26.8 millimeters and the refraction before the RK, then I rather believe the pike with a radius of 8.7 millimeters. Because with RK, every 1/10 millimeters flattening of the cornea makes about 0.6 diopters in the corneal refractive power. For example, 9/10 millimeter flattening about 6 to 7 diopter in the refraction. And if we assume that everything went well with the RK, and if we assume a radius of currently 9.5 millimeters like the Pentacam, then we are 1.8 millimeter flatter than normal, which then accounts for a good 10 diopter correction on the cornea or refraction. And so much was not corrected. No, so much had not been corrected. Therefore, I and we believed more the Siemer topography. And here you see the difference between Pentacam and Siemer again. And we did not take the Technis lens because we did not want to fully correct the spherical aberrations, because the centering of the lens and the angular alignment are very important. Unfortunately, you only have limited control over this during surgery. And if you use the Technis lens, this is what Professor Langenbucher wrote to me, it may be that the cornea resents you because of the asymmetry due to the RK, and strong photopic phenomena will occur with the large pupil. And if everything were nice and symmetrical, then the Technis lens would be the ideal lens for this spherical aberration. And with the Wergens formula for a thick cornea, he calculated a 20 diopter lens with a Hoya Vivinex for a target refraction of minus 2.42 diopter according to the prediction. So I changed it for half a diopter, and these are my results. As you can easily see, the patient must be very happy and has become very happy. Thanks to Professor Langenbucher with his IOL proposal, I would have been even more precise, and the patient is very happy, and thank you very much. In conclusion, patients with post-RK or post-LASIK are coming in more and more now for cataract surgery. It is better to do biometry with different machines, and you should check the data for plausibility. For every biometry which is done, it is best to ask as standard. First, has there been done any surgery on your eyes? Second, do you wear contact lenses? There has to be a contact lens break before biometry. And do you wear them now? Thanks for your attention.
Thank you, Stephanie. I think that was really a challenging calculation and case. Thank you for sharing that. So I open the discussion.
Yeah, Stephanie, that was super interesting. And for all of us, because any of us who have been faced with this problem, and all of us are in that space, for me, it's probably the very biggest challenge is getting biometry right in the previous RK patient. What I'd like to know is you went to a lot of trouble to try and figure out what lens to use. But at what stage do you make the final decision that you were correct with this whole process? And why I'm asking that is I've sometimes seen patients who at week 1 are maybe completely off target, maybe -5, because they have swelling of the incisions, the cornea hasn't settled down yet. And then eventually at 6 weeks or even later, 3 months might be exactly on target or closer to target. So what did you use, or how do you approach that aspect? At which stage do you make the decision that you actually achieve target?
In this case, I think it was the plausibility of the final lens I took. You always have to keep in mind what was the patient before RK or before refractive surgery. I wanted to point out with my presentation how important it is to do topography before surgery, because we have now many patients coming in having had LASIK or RK. RK, you can see it at the slit lamp, but LASIK, you cannot see it. And then you totally are wrong later on if you only take, for example, a SRKT formula. In this case, I had the old documentation from 30 years before, and I know that the patient had at that time minus 6.5 diopters, and therefore I could see, I revealed this with Professor Langenbucher, who told me, you did not cut 10 diopters like the Pentacam showed you. In the Pentacam, the cornea was so much flattened that it could not have been right. But I only realized it when I had the second topography, which was with the Sima Galilei. And therefore, yeah, I had to believe in the Sima Galilei and the calculation Professor Langenbucher helped me with.
Okay, you know, Stephanie, I was very interested in your case because RK was performed in Spain very frequently in the 80s, very frequently. We had the Fyodorov boat in Gibraltar, and they did thousands of cases and with more than 22 cuts, some of them. So you can imagine the type of cases we have, even with a 2mm optical, so amazing, right? So I have found a difference in the performance from the IOL Master, the previous IOL Master, the 700. You know, in this model, in spite of what is said in your presentation, that I think is quite instructive. You know, we have found that it's quite accurate, but there's no study to confirm. You know, but it's in our hands to use the keratometry of the IOL Master 700 in these cases. Provides a very accurate measurement in the visual axis, because this measurement is taken in the visual axis. So what we do now, we do topography, obviously, we do everything. I think that your presentation is fantastic in terms of medical education, but finally, we are relying more and more, and there is no final decision, you know, in the measurement of the IOL Master, because number one, is measuring the visual axis. Number two, it seems that the technology has improved to be more accurate for any reason that I ignore. And number three, because the outcomes are good. You know, we evaluate the outcomes in these cases only after 3 months, because as previously you mentioned as well, these patients are unstable, and you can take more than 2 months until you really get the final visual and refractive outcome. And initially they are hyperopic because the tremendous shift that you suffer in the corneatography because of the biomechanical imbalance. But this is my point, you know, if we have a device like the IOL Master that measures the key values, the visual axis, might be that this is the way to go. What do you think, and do you have any opinion about that?
I'm not that convinced of an IOL Master in patients after refractive surgery. I see I've been working now with the IOL Master 700 for a year. We have many IOL Master 500s, and there's a big difference between the both. But with the IOL Master 700, I was so happy that I thought I can now calculate all my toric lenses with it. But I even see really differences if I calculate my toric lenses with the IOL Master 700, and if I calculate the toric lenses with the topography and then the company own calculator. And therefore, I do not believe so much in the IOL Master. I think in these special cases, it's very important to have not only one machine, to have different machines like IOL Master, like topography, then to compare them and to see which results might be most plausible, most objective.
I agree, you know, but you know, I was with your idea, but since we have the evidence of several cases in which we were relying in topography and we ended in a refractive surprise, then we recalculated using the IOL Master key values, and they would have been better. Actually, we did piggyback, and the outcomes were exactly what the IOL Master 700 were mentioned. So it might be, you know, this is, I'm guessing because I don't have any systematic analysis of my data, but I can tell you in the last probably 10 cases, the results have been really quite accurate. And that, when I mean accurate, is within plus minus one. We're not that accurate, you know.
But I do not agree. You have to have systematic analysis, because the one thing is your feeling, but the data can be the other way around. Therefore, sometimes I think I have plenty of LASIK patients having undergone cataract surgery. Then I make a data analysis, and I see, oh, it's only half of them I thought, you know, feeling and data is a difference. And in this case, we need really a strong data analysis.
Absolutely right. But I'm referring only to RK cases, not to LASIK.
Okay.
LASIK is a different animal. Thank you.
Stephanie, I just want to quickly add something, if you don't mind, because it's a big, difficult topic. And there is one way you can make it slightly easier. And you and Jorge both mentioned that having a number of devices helps. So I think what we typically do is we use the Barrett TrueK formula for RK. We use the ASCRS calculator for RK. And then we do an SRKT formula. And the K value that we use is off the Pentacam, the Holiday EKR equivalent at 2.8 millimeters. So we look at that very small optical zone. We use those three collectively. And then what we do is we normally use the mean of those three. And then the last thing we do is we typically aim, especially if there's been a history of progressive hyperopia, we aim for maybe -1, maybe -1.5, and explain to the patient. So, but I think it's quite tricky. And that approach of using those three data sets for us has given us a very nice outcome over many years.
Yeah, it's time consuming, but it's worthwhile doing it for the patient.
Yeah.
I think Stefanie Schmickler has solved this case brilliantly with the help of a German professor. It's always good to have all the devices Arthur mentioned. It's also very good to have online a German professor specialized in optics, and that turned to really work in this case. Congratulations. And I also like, Stefanie, that you didn't dare to implant any complicated optic IOL behind this complicated cornea, because the alignment of these two complex optics might be not really the best. So I think, yeah, you did just you solved it the best way.
Thank you.